Okay. So you know the sensitive
Greetings and a warm welcome to everyone. May I have your attention, esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the Education Assistant to ensure a seamless experience. Clarinet is India's most relied upon digital platform, offering a multitude of enriching services specifically for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neurology Forum, Gujarat State Chapter, and the focus of this session is case presentation on neonatal sepsis. Now, without wasting any further minute, let's begin this session, for which I would like to invite Dr. Kunal Iyer, sir, the Honorable Secretary of the Neonatal Gujarat Chapter, to start the event today with his enlightening words and for the further coordination. So that is all yours, sir. Please proceed.
Yeah. Thank you, Ritu, for the kind introduction. So today we are continuing with the Neonatal Pathshala, that is every Wednesday between 3 to 4 p.m. We are conducting this online session, and today we are having the case presentation. For this case presentation, we are having Dr. Jatin Unadkat as the moderator for the session. He is the consultant neonatologist at Mahi Newborn Care Center, Rajkot. And we are fortunate enough to have Dr. Biraj Thakkar with us. Uh, Producer. So she will be the expert for this session. As well as we have Dr. Asmita Tripathi, who will be presenting a case on neonatal sepsis. And Dr. Dara Gosai has mentored Dr. Asmita Tripathi. And thank you so much, ma'am, for helping us with this. Without any further delay, unfortunately, today Dr. Shwetal ma'am is not able to join. So without any further delay, I would request Dr. Jatin Yanadkat to moderate the session and introduce the other faculty members.
Yes, hello.
Yes, Jatin, you are
Yes,
audible.
good afternoon, everyone. Uh, Today's topic is on case presentation by Dr. Asmita Tripathi on neonatal sepsis, and the mentor is Dr. Dara Gosai. She is right now Associate Professor of Pediatrics in BJ Medical College. She has been a national trainer for basic and advanced NRP, facility-based newborn care, and many other national programs. She has published more than 25 publications in various states and national articles, and she will be the mentor for today's case. Uh, Today, the expert will be Dr. Viraj Thakkar, ma'am. Warm welcome to both of you, ma'am. Viraj, ma'am, is right now in charge in Akanksha NICU Anand, Gujarat. She has done DNB Pediatrics and Fellowship in Neonatology from Nirmal Hospital, Surat. And she has been very active and still she is national faculty for point of care ultrasound and many other national programs. I'm handing over mic to Dr. Ashmita. She can start over with the case now.
Uh, Good afternoon, respected faculties. So I'm going to present a case of an unit, and my mentor is Dr. Dhara ma'am. I am Dr. Asmita, third year resident from BJ Medical College. And can I proceed?
Yes, you can
Yes,
start,
yes.
start step yours.
Thank you, sir. So I'm going to present a case of a baby of Rachna, 37 weeks plus 4 days old, delivered cesarean section, appropriate for gestational age, male neonate, born out of a non-consanguineous marriage, delivered at the Institute of Kidney Disease Research Hospital on 24th of May 2024 at 11:47 a.m. The neonate cried immediately after birth and was admitted on third day of life in view of respiratory distress following birth. So, birth history. The newborn was single, live, born out of cesarean section, done electively in view of precious pregnancy. Mother was induced and observed for initially 12 hours Even after that, there was no labor pains. She was taken electively for a cesarean section. The birth weight of the neonate was 2.7 kg and the APGAR score was 8 by 10. Obstetric history. Maternal age is 26 years old. Her height was 166 centimeter. Her weight was 60 kg and the BMI came out to be 24 kg per meter square. Active married life was for 6 years. Their marriage was non-consanguineous. The mother was gravida 5, para 0, abortion 4, and live issue was this child. LMP was 13 September 23, and expected date of delivery was around 27 April 2024. Mother had 4 recurrent pregnancy losses. All of them were of 10 to 12 weeks of gestations. After 2 abortions, the mother was investigated for the recurrent abortions. And it came out to be that the mother was diagnosed with septate uterus. And 2 years back, she was operated for the same. After that, also, she had 2 recurrent abortions. So she was eventually investigated for the antiphospholipid antibodies, cardiolipin, and lupus anticoagulant antibodies, which also came out to be negative. And the mother and father karyotyping was also done, which was normal. Antenatal history. The mother was regular in her visit. She had 10 to 11 visits at IKDRC Hospital, Ahmedabad. Her ultrasound was done at 3 and 5th month of ANC, which was normal. And she has taken 2 doses of tetanus toxoid and iron folic acid was taken regularly by her. She was a booked case at 8 weeks of gestational age, and the conception was spontaneous. As in view of the precious pregnancy, cervical encerclage was done at 14 weeks of gestation, and it was removed at 28 weeks of gestation. There was history of frequent urination and abdominal pain since 1 week before the neonate was delivered. There was no complaints of fever with rash. There was no history suggestive of pregnancy-induced hypertension, which includes blurring of vision, pedal edema, headache. There was no history suggestive of gestational diabetes mellitus. That is, her oral glucose tolerance test was normal. She was not on any thyroxine supplements. There was no history of leaking per vaginum, premature rupture of membranes. There was no complaints of urinary tract, no history suggestive of urinary tract infection, and there was no history of any drug intake. Then postnatal history. Immediately after birth, on 24th of May 2024, the neonate had difficulty in breathing and chest indrawing. It was acute in onset. The neonate was kept on O2 support immediately after that. That is the nasal prongs. And the neonate was shifted to a private hospital in Ahmedabad. According to the mother, there was some blood investigations done in the private hospital and a chest x-ray was done. As the mother said, the chest x-ray was suggestive of pneumonia as they have been informed by the residents over there. And some IVA medications were also given to the neonate. Eventually, the child didn't improve and they took leave against medical advice from there and shifted to the civil hospital Ahmedabad at completed 48 hours of life. Course during hospital stay. The neonate was received in civil hospital Ahmedabad on nasal prongs with intravenous catheter on left hand and orogastric tube in situ. On receiving, the temperature of the neonate was 36.2 degrees Celsius and the saturation was 82% on nasal cannula. The capillary refill time was borderline, that is 3 seconds, and the pulses were feeble. The RBS was 102 milligram per deciliter. The Downey score calculated was 6 by 10. The child had severe chest indrawing and the child was gasping as well. The respiratory rate was 70 per minute. On seeing this, the patient was immediately intubated and kept on the ventilator support for around 2 days. After 2 days, considering the sepsis, the neonate was started with first-line antibiotics, that is piperacillin, tazobactam, and amikacin, and other supportive management was started simultaneously. As pulses were feeble and CRT was 3 seconds, a fluid bolus was given. And after that, the child improved. The pulses were also palpable and the CRT became less than 3 seconds. On sixth day of life, the neonate was shifted to high frequency nasal cannula from the ventilator support for 2 days. After that, OFO2 trial was given. On the basis of blood culture, which came on 31st of May 2024, it was CONS, that is coagulase negative Staphylococcus aureus, which was sensitive to cefuroxime, cefoxitin, linezolid, vancomycin, and meropenem. So according to the sensitivity, the antibiotics were shifted from the first line to the second line, that is injection meropenem and injection vancomycin. For the feeding part, he was fed with a orogastric tube with express breast milk. After the at the third day of life, the child improved gradually and then shifted to the stable ward for the establishment of the breastfeeding. The feeding history. The neonate was kept nil per oral till second day of life. Then the feed was started with orogastric tube on third day of life after the patient was stabilized. And then the feed was increased gradually. The neonate was fed with expressed breast milk only. Eventually, as the neonate improved, the breastfeed was established. The immunization history. The neonate was given vitamin K at birth in the IKDRC hospital, but the birth vaccines were not given. And it was given in our institute as the child improved and was discharged. The family history. The father of the neonate was 36 years old and the mother was 24-year-old. Both of them have done graduation, and father was a manager in a textile company and mother was a housewife. There was a positive history of hypertension and diabetes and hypothyroidism in the grandmother of the neonate. Otherwise, no other significant history was there in the family. According to the pedigree chart, this was the only single issue of the couple. According to the socioeconomic history, the family falls into the upper middle class according to the modified Kuppuswamy scale 2024. Now the examination on receiving. The neonate was referred from private hospital on nasal cannula. The baby has been examined with all aseptic precautions and adequate light exposure. So on receiving, the vitals of the baby were the temperature was 36.2 degrees Celsius, measured via temperature probe in the radiant warmer. The heart rate of the neonate was 180 per minute, low volume, regular. All pulses were feeble. No radioradial or radiofemoral delay were appreciated. Then respiratory rate was 70 per minute and it was regular. CRT was borderline, that is 3 seconds. The saturation was 82% on nasal cannula. The BP measured via the NIBP was 70 by 36 mm of mercury taken at the left arm at the level of heart. Color of the baby was dusky on arrival. On general examination, there was no pallor, jaundice, cyanosis, or edema. On anthropometry, the weight of the child was 2.7 kgs, length was 51 centimeter, head circumference was 34 centimeter, and chest circumference was 33 centimeter, which was normal. In head-to-toe examination, the head was normal. Fontanelle, both of the fontanelles, anterior and posterior, were palpable. Anterior fontanelle was around 2 into 2 centimeter and it was leveled. Posterior fontanelle was palpable of about tip of finger and it was also leveled. No facial dysmorphism was seen. Neck and chest was normal. Umbilical cord was dry and clamp was present. No meconium staining or discharge or bleeding or umbilical hernia was noticed in the baby. Genitalia was normal. Back and spine was normal. Extremities were pale in view of the shock. Now, systemic examination. As my neonate was having severe chest indrawing, so I went to examine the respiratory system part first. So the neonate was on nasal cannula support. The respiratory rate was 70 per minute. It was regular and synchronized. Nasal flaring was present. Suprasternal and subcostal indrawing was present. Intercostal and xiphoid retraction were present. Downey's score came out to be 6 on 10. On auscultation, bilateral air entry was equal, but it was decreased bilaterally on both sides. And bilateral crepitations were heard. And on auscultation, grunting was present. Now, after that, cardiovascular system was examined. In that, the heart rate was 180 per minute. Peripheral pulses were feeble, regular in rhythm with low volume, and all pulses were palpable. S1, both the heart sounds were heard, and there was no murmur, significant murmur. Then the nervous system was examined. The child was alert with normal sensorium. Cry, suck activity was good, and all the reflexes were normal. Then abdominal examination. The abdomen was normal in shape and size. There was no organomegaly, and bowel sounds were heard. So the provisional diagnosis: 3 days old boy, born out of cesarean section, delivered full term, weighing 2.7 kg, appropriate for gestational age, cried immediately after birth with a bad obstetric history, is a case of early onset septicemia, blood culture proven, which came out to be coagulase negative staphylococci, with fluid responsive shock with congenital pneumonia.
Okay. So this is a case of sepsis occurring to you, right, Dr.
Yes.
Ashmita?
Yes, ma'am.
And what I understood is you initially told the history where you just told me that the child was there on the ventilator, intubated, then was extubated on high frequency cannula.
Yes, ma'am.
And then you presented the examination which was there at the time of admission.
Yes, ma'am.
No current examination. Where is the child right now?
Ma'am, the child has been discharged from our side. The child has been stabilized, was stabilized and then shifted to the ward, the stabilized ward, nursery. And from there, breastfeed has been established and further investigations were done. The child was investigated for ROP and USG ultrasound brain was also done. After that, the child was discharged.
Yeah, so I think this everything should be mentioned, and ideally the examination should be the current examination, okay, the latest examination rather than presenting just the on admission. On admission, everything comes under your history. Again, I was a bit confused in your history while you presented regarding gastrointestinal history. So there you told that the second day of life, child had been started with the feeding. Can you go back to the history part? The feeding history. Feeding history. Yeah. Neonatal was kept kneel by mouth on second day of life. Is that true?
Yes, ma'am.
So, was the child with you from day one of life? Or
No,
was
ma'am.
this child been referred to you on day 3 of life?
Ma'am, the child was referred to us on the third day of life. 48 hours of life was completed. So at third day of life, the child was referred to us.
Okay. So then this NPO was the second day of admission. Was that true? Or have you presented the history of different hospitals from where the child had been referred to you?
No, ma'am. I have mentioned from the stay from in our hospital only.
Yeah,
And
so this child was kept kneel by mouth on second day till second day of admission. Then feed was started with the OG tube on third day of admission and increased gradually. Is that true?
No, ma'am. Actually, when the child came to us, that particular day, the child was kept nil per oral, and then in
So
the
what I am telling you, rather than day of life, it should be day of admission. So that was a bit confusing. That's what I meant.
okay.
Fine. So then unit was fed express breast milk. Okay, fine. So the blood culture which you had told, was that of admission or was that of different hospital from where the child had been referred initially?
That was of admission in our hospital only.
So what is the diagnosis of early onset sepsis?
Ma'am, actually, according to the recent Cloharty, it is given that up to 6 day of life, early onset septicemia is considered, and from the 7th day of life to 90 days of life, the late onset septicemia is defined, ma'am.
And according to the old definition?
Ma'am, according to the old definition, less than 72 hours of life is early onset septicemia, and more than equal to 72 hours of life is considered as late onset
Yeah. So
septicemia.
in both the cases, you can stamp it as a early onset sepsis. What is the definition for hospital acquired admission?
Ma'am, if the child acquired infection after the 72 hours of the stay at the hospital, then it is labeled as, ma'am, hospital acquired infection.
Is it 72 hours or 48 hours?
48 to 72 hours.
So can this be a hospital acquired infection?
Yes, ma'am. It can be a hospital acquired infection as well.
So there is something which make us to think about the early onset sepsis before the hospital acquired infection. What is that? Why did you keep a priority like, the first thing is early onset sepsis rather than not the hospital acquired infection? You are right, it is early onset sepsis is the first among the list, but why it is so?
Ma'am, the signs were developed during the birth only. At the time of birth only, the child had increased tachypnea. The respiratory distress was developed since birth only. So
Yeah.
that makes me think that it
Think
is.
about early onset sepsis. Yeah, correct. Okay. So in antenatal history, would you like to ask something else to rule out the early onset sepsis?
Ma'am, in antenatal history, the maternal fever is
Hmm.
the main chief complaint. Then we have to ask the premature rupture of membranes
Hmm.
if there is present for more than 18 hours, ma'am.
Hmm.
And then prolonged labor, ma'am, for more than 24 hours. That is
Hmm.
also significant. If there is any signs of chorioamnionitis in the mother,
So what are the signs of chorioamnitis to the mother which you would like to check in the history?
uh, ma'am, there would be maternal fever. There would be tachycardia, ma'am, and
Okay. At the time of labor, would you like to ask or check with the gynecologist something?
yes, ma'am. We can. There is also, if there is, we can also go for the vaginal swab culture of the mother. If there is any genital flora growing in the vagina, so that can also cause the early onset septicemia during the delivery when there is a vaginal delivery taking place.
Anything related to placental examinations? Who had attended the delivery? Where this child got delivered?
And the child was delivered in the IKDRC hospital, that is the kidney hospital in the Ahmedabad.
Okay.
So it was attended by the pediatrician there, ma'am.
Okay. So if you have attended this delivery, then you would like to even check for the placental examination, right? Just to rule out the sepsis. Then again, what about the paravaginal examination? How many PV was done?
Uh,
Again, you would like to check with the gynecologist. So that
yes, ma'am.
also adds on the some risk factor for the sepsis.
Yes,
Have you
ma'am.
heard anything about calculator, septic risk calculator?
Yes, ma'am.
What is that?
Ma'am, in the sepsis risk calculator, basically we look for the certain parameters in the mother. So first of all, we have to check for the uh, first that the per vaginal examinations, how many times it has been done. So, ma'am, if it is more than three, then it is considered that it can be a risk factor for the early onset septicemia. Then, ma'am, uh, there are a few points in that risk calculator, ma'am. Uh, First point is that per vaginal examination and clean hands during the labor, during the receiving of the baby. And ma'am,
Have you used that calculator? What is your unit protocol? Do you guys use that calculator or some risk factor or nothing?
ma'am, mostly we ask for the maternal history only, as we as we receive the baby from different private hospital and different centers. So we actually emphasize on the history only mostly. So in that we have history. If there is history of maternal fever, there is history of per vaginal examination more than three. There, if there is history of premature rupture of membranes, prolonged labor. So, ma'am, according to that, five factors we take into account, and if more than two is present, then we assume then, and with the clinic also with the examination of the baby, we keep the diagnosis of the patient as clinically septicemia, and we treat accordingly, ma'am.
Okay. Is there any role of gender?
I mean, some books it has been mentioned that the gender predisposition is more towards the female rather than male. It has been mentioned in some book.
Predisposition for females. So female are more likely to have a sepsis compared to male. Is that so?
I mean, only one book I have seen that it is written female,
The
male.
male is more prone to have a sepsis. So if there is a male child, then the risk factor is higher, isn't it?
Yes, ma'am.
Just check it out,
Yes, ma'am.
whether it's a male or whether it's a female.
Okay, ma'am.
Okay. Your baby is male or female?
Ma'am, male.
Okay, fine. How many abortion? Oh, there were 4 abortions you mentioned, right? Yeah. So at the time of admission, so the patient was managed outside, and that was with the simple oxygen, nasal cannula.
Ma'am,
So
ma'am, actually, they have also mentioned that some IV medications were given to the baby, but they were not knowing the actual medications, and there was no documents as well with the mother. So I was not able to actually analyze which antibiotics it has been started there.
okay, if this would have been at your place, then which antibiotic would you like to start? Would you like to start with the antibiotic or you would not? Because this child was having an Apgar of 8 by 10, was cried immediately after birth, right?
Yes.
So are there risk factor present to start with the antibiotics or not?
Ma'am, the risk factors are not present in this, according to the obstetric history, and the child's also the neonatal risk factors are also not there in this baby, according to the weight and the as the child is term baby as well. But the on the clinical examination and by the vitals, by seeing the vitals as well, so clinically through the examination only we I have decided that this patient is falling under the clinical sepsis. So with that we have actually started with the antibiotics.
No, no, you are right. On third day, I'm not telling you. I'm telling you about on first day. If this child would have been delivered at your place where you had attended the delivery, where
Yes.
you are aware about whatever risk factor you told me, okay, and with the child Apgar score, with the child having a respiratory distress, male child, 37 week, would you like to start with antibiotic or not on day
No.
one of life?
No,
Then what
ma'am.
your ideal plan of management?
Ma'am, initially, I would, if on examination the child is stable, the vitals are normal, and only the tachypnea is present. So initially, I would have assumed and I would have kept my diagnosis as transient tachypnea of newborn, as the baby is born out of a cesarean section as well. So I would have started with the oxygen support initially for few hours, and I would have waited for the I would have seen the child, the progress of the child. If the child have been stabilized, then this child would have been of transient tachypnea of newborn movement.
What is the role of oxygen support in transient tachypnea of newborn?
uh,
Where would you like to start with the oxygen support in transient tachypnea of newborn?
Ma'am, if the child is having fast breathing, that is more than 60 per minute, and the saturation is also not maintained, that is, the saturation is uh, uh, after the 10 minute of the birth of the baby, the saturation is less than 94%, then at that time, I would go for the starting of the oxygen support. Ma'am.
What is expected saturation at 10 minutes of life according to NRP? Is it 94 percentage?
92%.
Is it 92? Check it out according to the NRP criteria. Okay, fine. So, like, if the saturation at say after 10 minutes of life is 94 percentage or 95 percentage, but still the child is breathing at the rate of 85 per minute or 86 per minute, then would you like to start with the oxygen support? There is a tachypnea, there is a distress. Would you like to start with oxygen support? How the oxygen will help this child out? What is the main issue when child is having a tachypnea or distress, but the normal saturation?
Uh, Ma'am, when the child is having tachypnea, that means the child is using his accessory muscles for the respiration to take place. So mainly at that time, there might be like in transient tachypnea of newborn, there is fluid present in the alveoli. So for the displacement of that fluid from the alveoli, we have to ventilate the alveoli. For that, we give the oxygen support.
So, what is oxygenation and what is the ventilation? Will your oxygen help you out in ventilating a lung? What is functional residual capacity? Have your oxygen built up functional residual capacity? What is needed is air, not the oxygen. These two things are different. Ventilation is totally different than the oxygenation. So this oxygenation or giving of oxygen with the 1 liter will not help you out in maintaining the FRC or opening up of your alveoli, which has already been filled up with the water in case of TTN. So these two things are different. So just beware about the same, careful about the same. Okay, so in this case, the child you would have started with some support. Say if you have this blend of facilities available and a CPAP available or a high flow available, then you would have started with the high flow cannula, right? So
Yes,
what is high frequency nasal cannula? What is the full form of HFNC?
ma'am, it is high frequency nasal cannula.
Is it high frequency nasal cannula? That is a high flow nasal cannula, okay? What is the full form HHHFNC?
Heated, humidified, high frequency nasal
High flow.
high flow high flow nasal
High flow because you are giving high flow. So what is called the high flow?
Ma'am, in that we can go up to 8 to 10 liters per minute. We can go up to the flow, which we cannot give through the low flow nasal prongs.
You
In
can
that,
go up to even if with a pediatric patient, you can go even up to a 20 liter, 30 liter adult. The point is the flow beyond 1 liter, that is 2 liter and more than that, is a high flow. It is heated and it is humidified. So that's why the name is heated humidified high flow cannula. So that was not the high frequency cannula. While presenting, you mentioned it was a high frequency cannula. So I was like, What is this? So that is not the high frequency, that's a high flow nasal cannula. Probably you meant that only, but the pronunciation or the understanding was bit different. Okay. So this child, when came to you, okay, fine. We were at the to start whether to start antibiotic or not to start antibiotic. So what is the guideline? Which guideline do you guys follow in your unit for starting an antibiotic for the early onset sepsis? Where to start and where not to start?
Uh, Ma'am, first of all, we take the detailed history of the patient. With the history, through the sepsis calculator, if we have more than two risk factors in the antenatal history, then we also we recheck with the history. We take the neonatal examination into account as well. If both of them are favoring the clinical sepsis, then we start with the first line antibiotic according to the our unit guidelines. And then if there is some mismatch, if we have some doubt regarding the sepsis, like if only the history is favoring and the examination is not favoring, like if only one through the antenatal history only one risk factor is present, and if the examination finding is not favoring, then we don't start with the antibiotics. We wait for some time, we observe the baby. If we find some findings in the examination, like if the child tachypnea is getting increased and it is not improving, and the child is also going into shock, and the child might develop if the child is developing some signs of feeding intolerance, at that time we suspect the child to be having clinically sepsis, and then we start with the first line antibiotics.
So is there any difference if the child is preterm and non-preterm? What is the guideline? More than 35 weeker, less than 35 weeker, the guideline is different.
Yes, ma'am. So, ma'am, in more than 35 weeker, first of all, with the antenatal history, if the history is suggestive and the examination finding is also suggestive, then we have to start with the first line antibiotic. In less than
Do
34
you like to
weeks,
consider risk factor in the history in case of more than 35 weeker baby with the early onset sepsis? More than 35 weeker, if there is a signs of sepsis, collect blood culture, start with the antibiotic or wait for the time, and then if culture is positive, then start with the antibiotic. Less than 35 weeker, you just go for the risk factor. If risk factor is there, then you would like to start with the prophylactic antibiotic. But every time blood culture is to be collected,
yes, ma'am.
right? So what is the routine protocol in your unit to start take the blood culture? When the
Ma'am,
blood culture is to be taken?
ma'am, blood culture is taken before the starting of the antibiotics. The Before we start antibiotics in any neonate, we take the blood culture sample, ma'am.
Okay. And then anywhere else after that?
Ma'am, after that also it is repeated. If it came out to be negative, then after 12 to 24 hours it is repeated, ma'am. If the clinical signs are strongly suspicious of the clinical sepsis, ma'am.
Okay. What about changing antibiotic?
Uh, Ma'am, for the
What
change of
about before changing antibiotic? Yeah.
Ma'am, first of all, before starting the antibiotic, we send a culture sample, and after we get the blood culture and sensitivity according to that, we change with the antibiotics, seeing the status of the patient as well. If the child is improving and the child is gaining weight and the child has come out of the oxygen support, the child has come out of the shock, then most of the time we send a repeat blood culture. If we get a positive blood culture of earlier what we have sent, we sent a repeat blood culture to check once again. And if if the child is not stabilized till now, the child has not come out of the oxygen support, the child is still on oxygen support, the child is still in shock, and the child is not taking feeds well, at that time we switch over to the particular, we consider that particular blood culture sensitivity, and we change the antibiotics according to that.
No, you have started with the antibiotic. Before starting antibiotic, you usually send a blood culture.
Yes, ma'am.
According to culture you change, that's a different thing, okay? But in case if your culture is negative and clinically there are signs of sepsis, if you think about changing the antibiotic or upgrading the antibiotic, before that also you should change the blood culture. That's what I meant. So the
Yes, ma'am.
criteria for sending a blood culture is before starting or upgrading or changing the antibiotic. So that is a one line statement only. Okay.
Yes.
Okay. So what was the CBC and CRP for the trial investigation?
Ma'am, the investigations were at the time of receiving, ma'am, 26th of May, the hemoglobin was 15.9. Total count was 3,800. Differential was polymorphic predominant, that is 54%, and lymphocytic was 33%. Platelet were 3.7 lakhs, and in the absolute neutrophil count was 1,576. CRP was 14.2, and the pH was 7.3. In one ABGA was also done, in which pH was 7.3. The PO2 was 94 and PCO2 was 55.6 and bicarb was 17.3.
Was there an admission ABG or is this on ventilator? Because you immediately intubated the child, right?
Yes, ma'am. This ABGA was done when the child was on ventilator.
So what was the parameter you started with?
Initially we started with the PEEP of 5, FiO2 of 40%, and the FSET was uh, 35, ma'am, and the PIP was kept at 16, ma'am.
So what was the mode of ventilation for this child?
Ma'am, the mode of ventilation was in the synchronized IMV mode, ma'am.
SIMV.
We have not kept in the assisted mode, ma'am. We first kept in the SIMV mode only, ma'am.
Okay. So what parameters would you like to change after looking at the CABG report? Did you change any parameters? Fine. Did you repeat the ABG? Because the CO2 was 55. Did you repeat the ABG? What is your interpretation of this ABG? Forget about everything. What is the interpretation of the ABG which you have presented?
Ma'am, there is metabolic acidosis in this ABG, ma'am.
Okay. Anything else? Any comment about the CO2? Is this the normal CO2 level? What is the normal CO2 level?
Ma'am,
Okay, fine. Go ahead. The
40.
next investigation. Then the CRP came down to
Yes,
8.2.
8.3. Then after that, the CRP was on decreasing trend only. It came out to be 2.6, then 0.1.
So
Also,
can you mention when did you change the meropenem and vancomycin? On which report did you change to meropenem and vancomycin?
it came out to be on 31st. We have received the child on 26th. So after 5 days of the admission, we have changed.
The child was already been extubated, right?
Yes, ma'am.
You mentioned that the child was extubated in 3 days. The child was on the high flow nasal cannula after 3 days. Here, the CRP has also decreased from 14.83, from 14 to 8.3, where the child has also improved. So, do you think that your first antibiotic even would have worked?
Ma'am, the CRP has been improved, but still the CRP is on higher side only. And the ANC is also decreased only less than 5,000, even with the first line antibiotic. even though the child has extubated from ventilator to airvo support, but we were not able to wean off the child from the high flow nasal cannula, ma'am. So that's why we went on to upgrade the antibiotics.
Okay, fine. What is the role of procalcitonin?
Ma'am, the procalcitonin is also inflammatory marker, which is also is a ma'am. Now it is not a part of the septic screen, uh, but it is a sign of inflammation, and it is a ma'am non-specific sign of the inflammation. If the child is having any kind of inflammation other than that of the sepsis, the procalcitonin may rise, ma'am. So, from the many studies which have been seen, the procalcitonin sensitivity and specificity is a bit reduced to diagnose the septic screen, ma'am. So that's why it is not followed in the recent guidelines, ma'am.
Is it the recent evidences which tells that the sensitivity and specificity of PCT has decreased?
Yes, ma'am.
Okay. Just a minute. Okay. So is there a role of PCT or a CRP in stopping the antibiotic?
Yes, ma'am. It is mentioned in Klohati, ma'am, that serial CRP measurements can be done. And after seeing the serial CRP measurements, if it is coming down and it is coming down from below the 1 mg per deciliter, then we can stop with the antibiotics, ma'am.
Earlier
Aligned.
as well, yeah. Fine, go ahead.
Uh, uh, then the septic screen was repeated on 6th of June. At that time, the total count was 7,530. The ANC has also been improved to 2,334. The CRP was 2.6. And on 8th of June, the total count was 10,600. The ANC was 4,028 and the CRP was 0.1.
Okay. Can you show the X-ray? Yeah.
So, ma'am, the left side X-ray is the X-ray which was obtained at the time of admission, and the right side of X-ray was at the time the child was on high flow nasal cannula.
Where is the tip of ET tube in the left-sided X-ray?
Ma'am, the tip of the tube is above the carina, ma'am.
Yeah. And is the NG tube in C2 or not?
No, ma'am. NG tube is not.
So what is the diagnosis from the X-ray? Anything specific?
Ma'am, from the X-ray, there is a patch present over the right-sided middle zone of the lung, ma'am. So that was suggestive of the pneumonia. As well as there is prominent reticular shadows present in the right lung, and
Fine. So can it be a congenital pneumonia?
ma'am, in this X-ray, as the RT is not in situ, so it can be a double bubble signs.
ए आरटी कहाँ आ गई? Congenital pneumonia.
हाँ मैम, congenital pneumonia. Yes, ma'am.
Oh my gosh. Okay, go ahead. I think you need tea. Okay, go ahead.
Then, so blood culture we have already discussed. Then 2D echo was done of this patient, which came out to be normal. USG ultrasound brain was done, which was normal, and ROP screening was done, which came out to be normal. And during the time of discharge, OAE was also done, which was bilateral ear pass.
What was the time when you get the ROP done?
Ma'am, the ROP was done at the time of discharge, ma'am. So after at the 14th day of life, ma'am, the ROP was done.
Okay, fine. What was the indication for getting the 2D echo done?
And the 2D echo was done as a part of screening process only. Since the
What you
child
wanted to screen from the echo?
ma'am, from the for the congenital heart defects, ma'am, basically. Ma'am, because the patient was having congenital pneumonia, so it may happen that some murmurs might get missed through the auscultation, and the child may have a small congenital heart defect, which might not be critical congenital heart defect, but uh, because of that reason, the child may have developed congenital pneumonia.
Minor congenital heart defects might even be missed of any of the child. So would you like to get the 2D echo, screening echo done for each and every newborn who is getting delivered?
No.
So what screening test for the heart disease would you like to do for any normally delivered newborn? Is there any screening test other than echo? Is echo screening test or confirmatory test?
Ma'am, both screening as well as confirmatory.
Okay. So what is the other screening test? I don't think echo is a screening test. It's a confirmatory test. Okay, fine. What is the screening test to rule out congenital heart disease? Not the minor one, the major one.
Ma'am, a chest X-ray.
Have you heard anything about pulse oximetry test?
Pulse oximetry test.
No? Go and read about it. Okay, fine. Go ahead.
Done, ma'am.
Done?
Yes.
Fine. There was a, yeah. So in examination also I had doubt about your nervous system examination.
Yes, ma'am.
You said that the child was cry tone activity was normal, right?
Yes, ma'am.
Can you go for the nervous system examination? Cry suck activity good. And what you mentioned was your child was on arrival, the SpO2 was 82% even with the oxygen support, was having the severe distress. So do
Yes,
you
ma'am.
think that the hypoxic child will be having a absolutely fine nervous system examination? Is it possible?
Ma'am, the hypoxic child would be irritable, would be having excessive crying, ma'am, at the time of in the nervous system, if we see that.
Any hypoxic child can have a normal nervous system examination other than this patient. This patient definitely will not have. The patient whom you require to intubate immediately at the time of admission and you are writing that the nervous system examination is normal. I really doubt about that. But forget about this child. Do you think that any child who is having a hypoxia can have a normal nervous system examination? If yes, then what could be the diagnosis? Which child can have a normal nervous system examination with the hypoxia?
Ma'am, in some congenital heart disease.
Yes. So if
Yes, ma'am.
normal nervous system examination with a hypoxic child, everything is fine, then you would suspect a congenital heart disease.
Yes, ma'am.
Then there won't be any distress. Here, the child had presented with the distress, so I won't expect this much of the normal nervous system examination. Okay. Fine. So regarding extubation, so can you tell me that how did you, process from, how did you wean the child from the ventilator and then extubate it to high flow nasal cannula?
Uh,
The
Ma'am,
course,
initially,
for the respiratory course for initial 3 days. We have 3 more minutes.
yes, ma'am. So first of all, the child was kept at FiO to 40%, ma'am, and PEEP was 5 only. With the minimal ventilatory settings only, we have started with the child, ma'am. And initially, because the child was in shock, so the child was not maintaining saturation, ma'am. After we have given the fluid bolus to the child has improved after a few hours, ma'am. After that, the child was eventually, ma'am, within few hours, 4 to 6 hours, the child was regularly monitored, and then the FiO2 was decreased first, ma'am. Then eventually, when the FiO2 came till, ma'am, 21%, ma'am, then we came down on the PEEP support as well. After that, we planned for the extubation of the child.
So what was the last setting before you extubated the child?
Ma'am, the PEEP was at 4 and the PIP was at 15 only, and FiO2 was 21%, ma'am.
Okay, on which you extubated the child. And extubated to ERVO.
Yes, ma'am.
Okay. So would you like to extubate this child on the CPAP or would you like to start with the HFNC?
Ma'am, actually, in this patient also, we have first considered to keep the child in continuous positive airway pressure only. But when we extubated the child had good respiratory efforts. And so we observed the child for few, I've observed the child for few hours, for few minutes. And then I decided that the child might get settled with the high flow nasal cannula as well. So when the trial was given of high flow nasal cannula, the child settled in few hours, ma'am.
Are you aware about what evidences are there for CPAP or high flow? CPAP versus high flow.
Yes, ma'am. Ma'am, recently there are evidences that if the child is having issue with the positive pressure, that is the alveoli are collapsed, then we should more favor with the CPAP. And CPAP is actually the evidences has had shown that after extubation, it has in many studies it has been seen that CPAP has better good outcome than that of the high flow nasal cannula.
But the Cochrane says that for post extubation failure, high flow is also equally good. You may go for the high flow for post extubation. As a primary support, high flow is a failure, especially for the premature babies. But for more than 32 weeker, you can even try with the high flow for the primary support. Okay, so for post extubation, high flow is okay for this 37-weeker baby. Okay, that's it. Nice presentation.
Thank you, ma'am.
Kunal?
Yeah. Thank you so much. So it was a really great presentation and excellent discussion was being done. I hope that it will be helpful to all. Jatin.
Yes.
Can you tell Ashmita to stop sharing the screen? Ashmita, can you stop sharing the screen?
Okay.
Yeah.
Yes, it was indeed flawless presentation. Really good presentation, Dr. Asmita.
Thank you, sir.
And I'm thankful to Dara ma'am and Biraj ma'am especially for pointing out the even smallest points which can be improvised. Thanks.
Thank you, Jatin. Thank you, Kunal. Thank you, Dara
Yeah.
ma'am.
Yes, I think we can
Thank you. Thanks a lot for providing this opportunity. It was excellent discussion. Thank you.
So thank you everyone. Thank you, Smita, for the excellent presentation. Thank you, Dara ma'am, for being helping her out. Thank you, Dr. Biraj, uh, for being the expert and pointing out few the important things. Thank you, Dr. Jatin, for excellently moderating the session. I would like to thank ClearNet also for the seamless experience. Thank you all.
2 जो जतिन के पास में बैठी है. Okay.
Yeah. So, Ritu, we can wind up now.
So thank you so much, everyone, for sharing your valuable insights. I hope you had a seamless experience. So with all your permission now, sir, we are closing the session over here today.
Yeah. Yes.
Thank you so much, sir. So looking forward to host you again soon in another interactive session in the near future. Till then, stay safe and healthy and take care, sir. Goodbye to you all.
Goodbye.
Goodbye.